Wow, what a crowd. This is absolutely fabulous. I know there's some floor room over here, and there's one empty chair right up front, if anyone would like to take that chair. I'm Tony Hayes, and I am the president of Regis College. I also have a background in the health professions. I've been a nurse for almost 40 years now. I am honored to be moderating this event this evening, and I am more than honored to have 4 stellar panelists here to speak with us today about healthcare and the status of healthcare reform and where we're heading as a country in terms of healthcare. I'd just like to mention that this whole Obamacare healthcare reform is going to impact over 35 million people who did not have health insurance in the past. It's an incredible, incredible landmark in the history of Regis, in the history of the United States, and in the history of healthcare in the United States. Also coming from a nursing perspective, if you will, I would like to say that this has opened up a new era for nursing, particularly advanced practice nursing, and the opportunities are immeasurable. Without saying too much more, I'd really like to start our panel discussion, and we will have all 4 panelists do their presentations, and then we will be open for questions and answers after all 4 presenters. We will have people in the audience helping to facilitate the question and answer period with microphones for all of you to use. So please raise your hands when we get to that point when you have something you'd like to ask. I'd also like to say that we prepared 150 packets for the program this evening and ran out about a half hour ago. So Amy Anderson is putting together more packets for you to pick up when you leave this evening. I apologize, but I think that just says something about the level of interest and the level of energy and engagement that you all have around this topic area. First, I'd like to introduce you to John McDonough. John McDonough is a doctor of public health and also has a Master of Public Administration. He is a professor and director of the Center for Public Health Leadership at the Harvard School of Public Health. Please welcome Dr. McDonough.
Thank you. Good evening, everybody. Nice to be with you. So I have about 20 minutes to try to explain to you what the Affordable Care Act is. So I usually like to start by asking people 2 questions. First question I'd like to know is, how well do you think you understand the Affordable Care Act? And you have 3 choices. A, I know it so well, I wish I could forget some of what I've learned. B, I kind of knew it, but please don't ask me to stand up in front of a group and explain it. And C, I really don't know it too well at all. Okay, so nobody's looking at you. So A, you know a huge amount. Okay, B, kinda, sorta. Okay, and C, not too well at all. All right, okay. So second question is, how do you feel about this law? So A, on balance, and we're talking on balance, I'm happy it's law. B, on balance, I'm unhappy it's law. And C, I'm still trying to make up my mind. Okay? So A, happy? Okay. B, unhappy. Okay? C, still trying to figure it out. Okay. Thank you. So that's a good start. So I'm not here to convince you that you should like it or that you should dislike it. What I'm here to try to do is give you a framework so you can understand it and make sense of it. And so as this process of implementation and change and so much else goes on, that you've got some framework that will help you to make sense of it, because it actually can be made sense of, and it's actually not that hard. And so in about 19 minutes, I'm going to try to make you among the smartest people in the country on the Affordable Care Act, okay? First thing I'd like to say, though, is to understand, to put this in context, is This is a special law in this way. This is the only law in the history of the United States that has attempted to achieve what we call comprehensive health reform. Even, say, the other biggest law that's ever been passed in U.S. history on health care, the 1965 law that created Medicare and Medicaid, that was really just touching on access. This is much bigger, this is deeper. So, and what do we mean by comprehensive reform? So by comprehensive reform, and this is my definition, I'd say it's got to touch on 4 points. First point is it has to address coverage, meaning insurance coverage and access, because just having insurance doesn't necessarily mean that you always have access. Secondly, it's got to deal with reforming and improving the delivery of medical care and healthcare services in the United States, broadly defined, covering a lot of different areas. Third, it has to impact prevention, wellness, and public health. And fourth, it's going to get at something that we call health in all policies, otherwise known as the social determinants of health. Get at the things that really make people sick or well, like housing, like the environment, nutrition, the food we eat, so much else. And so the ACA is really an effort, and I will explain this as I go along, to really address all 4 of these, and that's why it merits the term comprehensive health reform. It really does. Now, you may think it does it poorly or not so well or well, but it clearly has the ambition to address all 4. So let me give you the essential key structure that you need to understand if you want to understand what the ACA is all about. So just like a book has chapters and a baseball game has innings, a federal law, a federal statute, is made up of what we call titles. So instead of chapters, we call them titles. And the Affordable Care Act has 10 titles. I'm going to give you some deeper descriptions of about 5 of them because I don't have that much time. But I do want you to look at the underlying structure, and you will get a sense of the ambition, the breadth, and the scope of this law. So Title I deals with private health insurance in the United States. If this title is fully implemented beginning next January 1, private health insurance in the United States will never be the same again. This is fundamental, revolutionary change in terms of the nature, structure, and regulation of the private health insurance industry. No going back, never be the same. Title II is a hoped for, a potential revolution in terms of the Medicaid program to make it genuinely the program that provides coverage to nearly all low-income Americans, and I'll give some more details on that. Title III is a hoped-for revolution in improving the efficiency, quality, and effectiveness of medical care as delivered in the United States, as well as major changes to the Medicare program, and I'll explain more about those. Title IV is what is hoped for to be the beginnings of a revolution in emphasizing prevention and wellness and public health more effectively in our healthcare system so that we actually prevent people from getting sick in the first place so we don't have to pay the medical bills to heal them or take care of them. Title V deals with the healthcare workforce to attempt to improve the healthcare workforce in an ongoing way so that we will have a workforce that is constantly better matched with the needs and the changing needs of the American population. Title VI, a number of different things. Sometimes I kind of call it the grab bag, but a major effort to combat fraud and abuse in Medicare, Medicaid, private health insurance, transparency, the Elder Justice Act to address elder abuse in American society. Title VII deals with a new kind of pharmaceuticals known as biosimilars, which is a generic-like version of biopharmaceutical drugs, which is the real growth in the drug industry and creates a pathway for the Food and Drug Administration for the first time to catch up with most of our developed nation competitors and allow the manufacture, marketing, and sale of biosimilars in the US market, and that will be coming over the next couple of years. Title VIII is a part of the law that was an effort to develop a new voluntary disability insurance program for Americans either temporarily or permanently disabled. That title has actually been repealed by the Congress and is no longer. Title IX are revenue measures to pay for about half the cost of the law, and I'll explain a little bit more about that. And Title X really is just amendments to Titles I through IX, which reflects the kind of crazy process by which the Affordable Care Act became law. Okay? So, 1, private insurance; 2, Medicaid; 3, Medicare delivery system reform; 4, prevention and wellness; 5, workforce; 6, fraud and abuse and others; 7, biosimilars; 8, repealed; 9, revenues; 10, just amendments to the foregoing titles. And that's what the Affordable Care Act is. Bottom line. So within each of these titles, there are subtitles. Within each subtitle, there are sections. There's about 1,000 of them in the whole law, so there's a lot in here. But whatever you hear about, whatever you hear is in the law, or sometimes when you hear things that you think are in the law but are not, you can slot them according to one of these titles, okay? So at the end of tonight, we're going to give you a quiz to see if you remember all of these titles, okay? Just remember 1 through 5, and you're doing well. Okay, let's go into detail on some of these pretty quickly, okay? So Title I about private health insurance. There's a lot in Title I that has already taken effect. For example, the ability of health insurance companies to impose lifetime or annual limits on policies is now illegal in all health insurance markets. The ability of parents to keep their adult-dependent children on their parents' health insurance policy up until age 26 is now required for nearly all health insurance policies. The requirement that health insurance companies spend at least 80 to 85 cents of every premium dollar that you give them on medical expenses as opposed to advertising, marketing, profits, executive compensation, or whatever, is now a requirement for nearly all health insurance policies sold by insurance companies in America, and a lot more besides that. The big changes, though, come next January, and they come in 4 ways, and you're not really going to notice them for the most part here in Massachusetts because they're already law, because the 2006 health reform law and preceding laws in Massachusetts already addressed most of them. But the key components are, number 1, systemic reform of insurance markets to eliminate the ability of health insurance companies to write policies on you based upon your previous medical history. So today, in 45 of 50 states, it is entirely legal for a health insurance company, if they choose to write a policy on you, to have you fill out a 99-question questionnaire, and that will detail every element of your personal medical history for your whole life. And if the insurance company sees that you have diabetes, that you have or had asthma, that you had a cancer episode, that you've ever been to see a psychiatrist or a psychologist, they are legally permitted in most states to refuse to write you coverage, or to write you coverage for, say, everything except your diabetes, or to say, yeah, we'll cover you, but we'll charge you premiums 2 to 3 times higher than everybody else because of your illness. Beginning on January 1, in all 50 states, that practice known as medical underwriting becomes illegal across the country. And instead we have a practice known as guaranteed issue, where insurance companies, if you are eligible, must write you coverage, and must write you coverage that doesn't discriminate against you based upon your own medical history. Okay? That's number 1. Pillar number 2, because of that, because of this regime called guaranteed issue, we have to have something that people have heard about called an individual mandate or individual responsibility, which says that if you can afford to buy health insurance, you have to do it. Because otherwise, younger, healthier people will wait until they think they need medical care before they buy health insurance. The price of health insurance will skyrocket for everybody, and the market won't work. So that's what the individual mandate is. We've had it in Massachusetts since 2007. It hasn't created any particular uproar or significant disruption for people, and it's pretty much working, and it becomes national law beginning in January. The third part are subsidies to make the purchase of insurance affordable for people who are now mandated to buy health insurance. And the fourth part is to create a new vehicle for American consumers to be able to buy health insurance in an easy, accessible way. Any of you ever used that website like Orbitz or Expedia to buy airline tickets or rent a car? How many of you have ever done that, right? Okay. This is like an Orbitz and an Expedia for health insurance. If you want to see how it works, just Google Massachusetts Health Connector, go on the site of the Massachusetts Health Connector and take it for a test drive yourself. But this is a way to create a vehicle for consumers who need to buy health insurance, who can't get it through their jobs because their jobs don't offer that coverage and they're not required to be able to go and buy health insurance and do it in a way that they've got some security that they're buying quality coverage. That's it. That's what Title I is. I can talk about it a lot longer, but that's the big change. Title II. Am I almost out of time? 5 minutes. Wow, this is amazing. Title II changes the Medicaid program fundamentally so that beginning next January, in states that allow it, in states that agree to go along with it, every low-income resident will be able to, citizen will be able to buy health, will be able to get health insurance coverage through their state Medicaid program. Lots of people think Medicaid is coverage for low-income Americans. It is coverage for low-income Americans if they fit into one of the categories. Beginning next January, there are no longer those categories. If you meet the income test and you are a citizen, not non-citizens, you can get into the program and you can get coverage. Okay? Title III deals with two things. Number one, it is to address the quality, effectiveness, and efficiency of American medical care through a series of reforms, the development of a national quality strategy, a series of demonstrations, experiments, other kinds of things, all attempting to move the American healthcare system away from a system that rewards providers based on the volume of services they provide, otherwise known as fee-for-service, and replace it instead with a structure that rewards providers based upon the quality, the efficiency, and effectiveness of the care that they provide through vehicles such as accountable care organizations, through medical homes, through something that is going on right now, which is penalties on hospitals that have very high rates of preventable readmissions, very high rates of hospital infections, and other kinds of things. There are other changes to the Medicare program. There are improvements in benefits, closing the Medicare Part D donut hole, the coverage gap, providing free, no-cost wellness visits, and a whole series of other clinical preventive services like mammography screenings and other kinds of screenings as well. And then there are changes as well to try to produce savings from the Medicare program that pay for about 40% of the cost of the law. Okay? Title IV, prevention and wellness, the development for the first time in the nation's history of a national prevention strategy, which you can read. It's been done. It came out in 2011. It's a very compelling document. Really an example when I talked about health and all policies, that is in Title IV of the ACA. A bunch of other things. In Title V is an attempt to really address the workforce issues and needs, promoting primary care, significant increases in funding for community health centers, a National Health Workforce Commission that was appointed that has yet been able to meet because Congress has not been able to agree on the funding to make it go forward. Okay? Let me just show you this, just have a little bit of a sense of how this holds together financially. So these are the major titles of the law. And what you can see under this is you recognize all these different titles now. You're never going to forget those for the rest of your life, right? You see in the second column in terms of covered, these are the estimates that were done at the time the law was signed in 2010 by the Congressional Budget Office for who would be covered. And the estimate was about 16 million Americans would get covered under Title I who didn't have health insurance, and 16 million would get covered under Title II, under the Medicaid expansions, for a decrease in the number of uninsured Americans by about 32 million. There will still be uninsured Americans. It's not going to cover everybody. If you want to talk in Q&A, I can tell you who that's going to be. The next column, though, tells you where the money's spent that cost this law. The 10-year cost of this law, as estimated by the Congressional Budget Office back in 2010 when the law was signed, about 3 years ago, was that about half the cost of the law is in Title I and half the cost of the law is in Title II. Okay? And then if you look at the last column, you can see where the law is paid for. Because the cost of this law, unlike many previous health laws, including the creation of the Medicare Part D drug program in 2003, is entirely self-financed. It's self-financed through new taxes. It's self-financed through savings. It's self-financed through reductions in reimbursement to various kinds of providers, not so much physicians, but insurance companies, new assessments and fees on drug companies, on medical device makers, on hospitals. And about half of those costs come from Title III, the Medicare changes, and about half of them come from Title IX, the revenue savings. Okay? So I think I'm out of time. And that's as far as I'm going to go. There's more in my presentation, and we can get to some of that in Q&A if you want. And other than that, thanks for your attention.